Neha. The next one is going to be Dr. Monica Bhandari. She is going to present Making Left Main Neo-Ostia.
And I thank you, WCC, for giving me an opportunity to present my case. My case is a 36-year-old male, hypertensive, diabetic. He's a smoker. He had angina history from last 3 months and presented to us with history of rest chest pain for 2 days duration. He was diagnosed to be a case of unstable angina. On physical examination, there was nothing abnormal. The ECG showed ST depression in inferior leads and echo showed concentric LVH and grade 1 diastolic dysfunction. We took patient for the coronary angiogram. The right coronary artery was normal. The left angiogram showed there is a significant ostial and shaft left main disease. There is involvement of ostia of LAD and LCX with Medina 1-1 classification. And there was also a mid-LAD disease of 80%. So what should be the plan we thought? We thought to send patient for coronary artery bypass grafting. His syntax score was 25. But while we were discussing about the plan of management, the patient developed chest pain on the table. So we took patient for coronary angioplasty. We plan to stent the mid-LAD first and then go for dedicated bifurcation stenting with 2 stents with Q-load technique. So we wired both LAD and LCX and pre-dilated with a 2.5 into 12 mm balloon, and we put a stent 2.75 into 38 mm DES in mid-LAD. Then we place the stent from left main to LAD 3 into 33 DES. So this is the stent we place from left main to LAD. So this is the angiogram. Actually, when we were doing rewiring of the circumflex, the wire went very easily and the balloon for strut dilatation also went very easily into the circumflex. So we were thinking whether we are going through the stent or we are going outside the stent. So there was a doubt whether the stent was placed well. So we took a stent boost. We saw that there is elongation of the left main stent and the stent got pulled and it is hanging into the aorta. So there was a challenge to put wire the LCX and put a LCX stent through this overhanging part of the left main. So we decided to create a new left main, ostia and left main. So we rewired circumflex. And this is how the wire went and the balloon. So we pre-dilated, we dilated the strut, and then we did the proximal optimization of the stent, left main stent. We pre-dilated the circumflex, and then we put the 3 into 23 mm drug-eluting stent into left main to LCX. And then we did the kissing balloon dilatation. Can we go back? And this is this is the final result. This is how we created the new left main ostia and shaft and new carina. Actually, the IVUS image was not running. This we can see here. This is the overhanging part of the stent. The pointer is not working. And the MSA was 11.9 millimeter square. So the take-home message are longitudinal compression of the stent is well known, but elongation is not commonly seen. In our case, probably the stent got pulled and got elongated during the withdrawal of properly uninflated balloon. Guide and wire position should not be lost in such situation. Otherwise, we won't be able to re-enter the artery. And once we can re-enter the artery, we can bail out the situation by placing another stent and optimize the result. Thank you.
It's really a very great case. You have really handled it well. Excellent case. In such situations, really keeping your nerves down and handling the procedure is really important. And then I would like to just ask, it is a complex procedure of LM, some kind of a backup for LAD like a temporary pacemaker or any other IABP or anything did you consider here?
Ma'am, the patient's vital were stable. His ejection fraction was normal, so we didn't consider for any left ventricular assist device.
So it was a really a bad LM and LED which was there. So it would have been helpful in such situations. It's really nice that you have done it. And otherwise, it was very well tried. Did you check the IVUS shots in the earlier stage or only after the procedures did you check?
After putting the stent, we did IVUS.
Do you think there is any thrombus in the LM and Australian lady? So it was looking like that. So I think you have to keep that in mind also. So for that you can check by IVUS. So then it becomes very simple. Another thing is, as you told, while removing that balloon uninflated.
Probably that was.
Yeah. So there are sometimes it happens. The stent becomes loose or get dislodged. Here it is pulled to some extent. So then did you do?
Visible angiographic.
Yeah. Did you do under fluoro that removal of that balloon? Sometimes actually what they do is nowadays because maybe people are so aggressive that they want to do less fluoro. So sometimes after putting the stent, they just remove the balloon or remove the wire without seeing the fluoro. So sometimes this can happen. So it is very important that you have to totally deflate the balloon and remove the balloon under fluoro. Then this can be prevented. And another thing is, you have done fairly well. Did you again did flare up in the aorta and Australian lady?
Optimization we did again.
Okay. Actually, patient gave a lot of time to you.
Yes,
Yeah.
he didn't crash.
So that, yeah, that's why. And I have a doubt whether the patient had got thrombus also. I don't know.
Why
I
did
feel
you
like
use a
that after
3
seeing that
mm
LM,
3
that
mm
haziness.
stent in the proximal
Okay.
part?
See, this patient has got ECG changes, L2-3 AVF vest elevation, you told, is it not? So, but RC is normal, maybe because of the L6 lesion. So, there are no ECG changes because there is LM, AVR, ST elevation, anything is there? Nothing is there. So, that is another interesting finding.
But now it is 2-year patient. I did it in April, not 2 years. April 2023, patient is completely asymptomatic now.
Okay. So, very good case, well handled.
It is a little smaller size in the proximal part. You should have tried with a 3.5 or 4. It would have been, you would have not end up having a, but it's good. Well handled.